I'm Dr. Brian Hwang, and I'm very happy to partner with Providence to bring this webinar. This is going to be on headaches and neck pain. So I'm going to spend the next 30 to 40 minutes first talking about sort of my background and what makes me qualified to talk about this topic, and then we'll do a deep dive into headaches and neck pain. Again, thanks again for joining. So here's a brief outline. So first introduction, I'll talk about sort of my background and my training experience, and then we'll discuss headache and neck pain. And specifically, we'll talk about, how in some people, these two conditions can happen at the same time or in a closely related fashion. And then we'll talk about two specific conditions in which we see headaches and neck pain affecting the same person in a similar way around the same time. And then we'll talk about treatment options. And then we'll spend a few minutes talking about this exciting sort of next generation treatment that I'm partnering with Providence to offer to people with sarcogenic migraine or occipital neuralgia. And that's neuromodulation. And we'll talk about that, and then there will be a Q&A. But at any point, if you have questions, don't feel bad. Just feel free to interrupt and ask your question. So first of all, I am a neurosurgeon, so I'm a surgeon who deals mainly with issues related to the nervous system. So that involves the brain, the spinal cord, the spine, the bones themselves, as well as peripheral nerves, all the nerves that leave the body and go into different body parts. I deal with them. And my main goal is to deal with usually structural and mechanical issues to make people better. So I work in conjunction with neurologists who mainly deal with, I guess the simplest way to put it is a software side of the nervous system, as well as medical doctors, because the nervous system is very sensitive to the overall conditions of the body. And so usually the nervous system, the brain and the spinal cord and the nerves go hand in hand with a lot of the medical conditions. So I do a lot of collaboration there. So I really started my journey into neuroscience and neurosurgery in New York. I arrived there shortly after college, and I really had no idea what I wanted to do. And I got lucky enough to get into a program that I found out later is one of the top in terms of neuroscience, neurology, and neurosurgery. And so I met some good mentors while I was there. They introduced me to the field of neurosurgery. I really enjoy working with my hands. I was an art major back in college. I did a lot of sculpting, so I thought that neurosurgery allowed me to combine my two passions, which is the nervous system and working with hands. So I spent an extra year in medical school doing a Doris Duke neurosurgery research fellowship, really confirmed my passion. And I decided to spend the rest of my life thinking and doing neurosurgery. So then I didn't move too far away from New York City. So I went to Johns Hopkins Hospital. At the time, it was the #1 program in the country. And I was very lucky to get into the program. I had a lot of people who provided excellent mentorship. And I did my internship, residency, as well as 2 fellowships, one in complex spine, which also combined robotic spine surgery, as well as fellowship in functional neurosurgery and pain. All in all, don't ask me how many years I was there. I was there for a long time. I stopped counting after a while, but it was totally worth it. And the hospital had somewhere in the uppers of 1,500 beds, including the main campus and the satellite sites. So there's a lot of people with complicated neurosurgical and neurological problems. And I was, thanks to them, I became the beneficiary of excellent education and training. And Hopkins really is an amazing training ground for neurosurgeons. And some people ask me, well, what the heck is functional neurosurgery? I mean, everyone knows kind of what spine surgery is, but what is functional neurosurgery and what's pain neurosurgery? And this is really where the most excitement is happening in the field of neuroscience and neurosurgery. So with increasing our understanding of the neuroanatomy, psychiatry, computational science, and with next generation computing like cloud computing and quantum computing, now we are really entering the renaissance period of neuroscience. As you probably hear in the news a lot, there's artificial intelligence kind of everywhere now. People are talking about these smart robots. They're ubiquitous, and with increasing interest among us in the brain, the nervous system, that really all that excitement and research and new knowledge is feeding into neurosurgery. So essentially, functional neurosurgery is a departure from the traditional neurosurgery, which was what we call ablative, meaning we go in and we take out tumor, we take out an aneurysm, or we take out pathology. So it was mainly going in and taking out something bad. But functional neurosurgery really is trying to understand in depth the nervous system and trying to use different technologies such as ultrasound or electricity or different mediums in order to regenerate the nervous system that's been injured by injuries or diseases, and to help people regain function. So deep brain stimulation, for instance, for Parkinson's disease, essential tremor, now we're talking about seizure disorder, all the way to a vagal nerve stimulator placement in the neck in order to help people regain their motor strength in their hands years after stroke. All these things fall into functional neurosurgery. And also pain. Pain is a huge problem in this society, and I was able to focus on neurosurgical treatments of pain, uh, also using advanced technologies instead of the traditional, very destructive and very high risk procedures. And rather than that, I was able to learn and really help push along the technologies to help people have meaningful pain control with minimally invasive to non-invasive neurosurgical treatments. So it's a really exciting field. And this is a slide talking about neuromodulation, which is part of functional neurosurgery at this time. And these figures come from research projects that I participated in, a lot of them funded by the Department of Defense and different agencies of our government. And you can see that there's a lot going on in the field of neurosurgery, and we're using these very high level technology, next generation technology, to bring back function to people who really had no hope in the past. And it was very fortunate to be part of these efforts while I was at Johns Hopkins. So during my training, I had an opportunity to really act on my childhood dream. I always wanted to serve. I'm Korean, and I grew up hearing about my family's escape from Korea and how U.S. came and fought the communist forces, and really allowed my family, as well as millions of Koreans, to have the life they would enjoy today. And so I was always looking for a way to give back. And for me, that took the form of infantry military service. So during residency, I had an opportunity to take about 5 years off. And so I was able to join the U.S. Army, really with a plan of doing something different. I knew that I wanted to come back and continue to serve through neurosurgery and medicine, but I want to serve in a different capacity. And somehow I ended up becoming a Green Beret after 2 years of grueling pathway and selection training, and served in combat theater. And now currently I serve as a technical expert for traumatic brain injury at the NATO, representing our U.S. Department of Defense, which is a big honor. So I really found it meaningful to serve our government through military service. So after I came back to Johns Hopkins to finish my neurosurgical training, because of proximity from Baltimore, where Johns Hopkins is located, to Silver Spring, Maryland, right outside of DC, I was able to pick up a job, a position as a neurosurgery neurosurgeon and medical officer at the FDA. So currently, I am a medical officer serving in the Office of Neurological and Physical Medicine Devices. And I basically look at all the neurosurgical and neurological and rehabilitation devices that are about to hit the market. And I have an input in terms of their safety and efficacy, make sure the studies are done well, make sure that the companies are not exaggerating their claims, really to protect the public, but at the same time expedite these very important critical technologies from benefiting people without unnecessary delay. So it's really been a gratifying and humbling experience, and I'm still active with the FDA. And what I try to do is bring the knowledge and the information I have, given because I have access to the information related to all the devices, I can really apply that information to my practice to make sure that the people that I take care of, have the honor of taking care of, can benefit from the latest information. So basically, my mission at this point is, as a neurosurgeon in Orange County, serving this area in partnership Providence, is really to bring an individualized approach to each patient I see. And because neurosurgery is not a static disease, it always transforms over time, it changes. I really emphasize on creating a lifelong partnership with the person who comes to see me in clinic. Again, because things will change inevitably with age and with life, and the approaches have to change to match that. So I always focus on that. Also, earlier I mentioned that I'm just one person. I'm just a neurosurgeon, and my specialty is very narrow. And so I try to partner with other physicians, different specialty, to learn from them and to exchange ideas. I really emphasize on communication, as I learned in the military, to ensure that all the providers are on the same page as much as we can, given the challenges of our healthcare system, so that the people I take care of can benefit from a tight teamwork. I also emphasize in conservative approaches, because surgery a lot of the times is not the answer. Surgery is harmful if it's not done in the right person at the right time. And so I emphasize on doing everything we can, including non-surgical management, to avoid surgery at all costs. And then evidence-based care. This is very important for me. Historically, medicine has been done really through anecdotes and dogma, but really, as time has passed, people have realized that medical care, neurosurgery care, has to be based on very well designed trials and studies. And so I always pay attention to that, so that I always do the right thing for each person I come across. And then the last piece is, due to my involvement with the FDA, I'm able to understand the advanced technologies coming through the pipeline. I do my very best to pick the ones that have truly demonstrated safety and efficacy, and try to incorporate that into my care. So with that, I'll stop talking about myself, and then I go into the meat of the discussion here, which is on headaches and neck pain. So headaches and neck pain is on everybody's mind. Why? Because everyone has it. Everyone has headaches and neck pain, or both of them, at some point in their life. And unfortunately, as we continue to get older, headaches and neck pain become very common. So starting around age 10 to 15, you see the increase in the prevalence of headaches and neck pain. And by the time you hit age 50, that prevalence really goes up to 70 to 80%. Pretty much everyone at some point in their life will combat not just any headache. I'm talking about some serious debilitating headaches and neck pain. And the awful thing about this is that a lot of times they happen at the same time. A lot of people say, I get neck pain that develops into headache. Sometimes I have headaches that go into my neck. Sometimes I have both at the same time. And it can be really, really debilitating. And I don't have to tell you how frustrating and annoying and debilitating headaches and neck pain can be. A lot of the headaches and neck pain conditions, or conditions that cause them, are related to age. And as I told you, as we continue to get older, and the population continues to get older overall, the headaches and neck pains become more common. And I'll touch upon this later in the lecture, but unfortunately, because headaches and neck pain are almost directly related to a degenerating body or depreciating body, age is definitely the biggest risk factor. But also, lifestyle matters a lot, and occupation matters a lot. Why? Because occupation and lifestyle kind of feed into the speed at which our body deteriorates. The more you use it in a certain way, the more you're going to deteriorate your body. You basically accelerate the wear and tear through the things that you do on a daily or a regular basis. So occupation and lifestyle are definitely two important risk factors for headaches and neck pain. And I just want to specifically mention that I'm not talking about the headaches you have once every blue moon, neck pain that happens, once every 6 months. I'm talking about chronic headaches and neck pain that happens frequently throughout a week and affects your quality of life in a significant way. And you'll notice that people who have had neck injuries or traumatic brain injuries or head injuries from a traffic accident, from a fall, even when, injuries that happened decades ago, can definitely be a risk factor for chronic headaches and neck pain. And that also feeds into the idea that I mentioned earlier, is that a lot of these pain syndromes are related to our body depreciating over time, the wear and tear, and injury can accelerate that process significantly by damaging the structures that keep things together. So I don't have to belabor this point, the headaches and neck pain, especially when they happen together, can be a cause of major disability and a factor that decreases quality of life. So I'm a surgeon, I'm a very visual thinker, and it has to make sense before I do anything. For me, and for any surgeons out there you speak to, anatomy is sort of the cornerstone of how we understand the conditions that we manage, how we kind of shape our discussions, when I meet people who have issues related to headaches and neck pain, and the managements that we come up with, like what we do. And I just want to let you know some of these things, like I didn't really learn even during residency. Like it really came from my experience of thinking about this problem, for a long time and meeting people with these conditions. So I just want you to understand the head and neck, the division, are really arbitrary. Head and neck really essentially they're one structure. And where the neck begins and it and ends, and where the head begins and ends are really arbitrary. And you'll see that it's almost continuous. And then the way that the head and neck are structured and wired with nerves are very, very complex. And the way the anatomy is set up in the head and neck and their relationship, it can largely explain why in a lot of people headache and neck pain happen together. So if you look at the diagram in the slide on the right side, you can see it looks pretty complex. It's a pretty upset looking person in different and depicted in different sides. You can see him facing you, see him facing away from you, and then we're looking at him from the side. And they're different numbers. Well, what does this all mean? This is actually a very important concept to understand. The nerves that go to your face that come out of your skull actually does not go beyond the top of the head. Again, so what this means is the part when it comes to feeling sensation, the head really stops at the top of the head. And this is actually really surprising because people say, well, my head is actually, it includes the back of the head, not just my face, but essentially the face and the top of the head, the crown, is where the head ends from a sensation standpoint. And then from the back of the head, if you look at the diagram, C2 actually stands for cervical number 2. So cervical number 2, the bone, is actually behind your back, way down here, where most people say, well, this is where my neck begins. But if you look at where those nerves go to give you sensation, It's actually in the top of your head in the back. And then they're organized in such a way that they just go down, cervical number 2, cervical number 3, cervical number 4, and so on and so forth. And so again, this slide highlights this point that not everything is intuitive. So again, the head, the sensation ends at the top of the head. That's where it stops. And then the rest of the head, the back of the head and the neck, the sensation is supplied by nerves that are coming from the neck. But I want to first talk about the headache component. So where does headache come from? Headache actually comes from within the skull. And it all starts with this nerve called a trigeminal nerve. And it's called trigeminal nerve because, as you can see in the figure with this person's head, there's a big bulbous structure here, and a nerve is divided into 3 prongs, like this trigeminal, like a trident, excuse me. And so it has 3 prongs to them, and they split and they go into different parts of the face. But what it also does is it actually goes inside the skull. It gives a sensation to this structure called dura. And the full name for this structure is dura mater, or in translation as Latin. So if you translate it, it actually calls tough mother. And no one knows why it's called that, but this is the part of the brain that has sensation. The brain itself does not have any feelings. So when we do a brain surgery, and then once we get through the dura, which is a tough covering of the brain, this part, it's almost like this leathery covering, and that is very, very sensitive, and that's where all the headaches originate. But once you peel that and then you get into the brain has no sensory endings. So I can touch the brain and the person won't feel a thing. Well, as soon as I touch the dura, they say, oh, I have a tremendous amount of headache. So basically what you need to take away from this slide is there is this nerve called the trigeminal nerve. It comes from the brain stem. It goes through the skull, and then it basically goes right into this wrap that surrounds the entire brain. And then it gives sensation that can be felt as headache. So again, what that means is that headache is coming from the brain. It is coming from the brain stem. Now this is one more slide on the trigeminal nerve. I know we're getting into a lot of details, but all you need to remember from this slide is, shockingly, although the trigeminal nerve is in the brain and of the brain, and it gives sensation to the face and the covering of the brain, it not only collects information from the face, it collects information from the upper spine, the C2, C3, C4. And therefore, based on this anatomy, if you have neck pain, the trigeminal nerve will sense that, collect it, and send it into the face and into your head, the covering of the brain, and it will generate headache. So there are people out there who have upper cervical, upper neck spine problem. It's a spine problem, the bone problem, but the trigeminal nerve sitting in the brain will pick that up, and then it will process it as if the pain is coming from the face or the head, and then give you this signal, which can be sensed as headache. Now let's move down to the upper spine. So upper spine is the spine. So if you see this diagram to the left, you see the skull. We're looking at this person from the back. The face is here, the nose is here, this is a jaw, and you can see the spine. This is a cervical number 1, number 2, and number 3. There's 7 bones in the cervical spine or the neck. And so they go in order, 1, 2, 3, 4, 5, 6, 7. So if you look at this, the spinal nerves are coming out of the spinal cord, the yellow structures. And where are all these nerves going? They're not staying in the spine. As I mentioned earlier, these nerves are coming from the spine, they're going into the back of the head. And that is why when some people have upper cervical spine problem, you can actually have pain in the back of your head all the way to the top of the head, and sometimes it goes into the front of the head, into the forehead. And this situation is called a referred pain, You don't have to remember that term, but you know how people say, or doctors tell you, well, if you have a heart attack, then you can have it shooting pain down your left arm. This is the same idea that when we're made, some of the nerves that are connected to the heart is dragged into your left arm, just like it is in this situation where some of the nerves in the spine are dragged into the skull. And so when you have an issue with the heart, you have pain in the left arm. It's the same situation here, where the nerve, when the spine has problems, it sends the nerves into the back of the head, causing headache. And now this is called referred pain. I know this is a lot of information, but if you look at this figure on the right, this is depicting this person's back of the head. And as you can see, when you have upper cervical problem, C23, C34, C45, they refer to the head, the back of the head. They don't stay in the spine. And that's the point that I want to make. And in fact, this is how it is for the rest of the body. If you look at this, not just the upper cervical spine, but the lower cervical spine and the rest of the spine actually refers pain to areas that has nothing, you think they have nothing to do with it. So if you have a lower cervical spine issue, I told you there's 7 bones in the neck in the cervical spine, and see what area C6-7, which is the lowest level, refers to pain to. It goes into the shoulder blade. But that's not where the spine is. The spine is way up here. So this is a very important concept to understand. So with that, I'm going to go into the 2 conditions specifically, cervicogenic headache and occipital neuralgia, 2 conditions that I manage as a neurosurgeon in which 2 things are happening at the same time, headache and neck pain. So for the rest of the lecture, I'm not going to talk about people who only have headaches and people only have neck pain. I want to focus on people who have neck pain and headache, which are both significant problems. Before I do that, does anybody have any question about the anatomy I reviewed or anything? I'll take any questions. Okay, so I'll continue. So let's talk about cervicogenic headache. What does that mean? Cervicogenic headache. So cervical is the neck, the upper spine. And so all this means is headache that comes from the upper cervical spine. This is a very poorly understood condition. And I realized that I didn't really understand it when I was in training. No one actually taught me this. And in fact, a lot of doctors actually are not familiar with this condition. This is not something that we talk about all the time. This part of the anatomy has been poorly understood for a very long time. And now with functional MRI and different types of imaging and different studies, now we're just beginning to understand that this is actually very, very common condition. So what does cervicogenic headache feel like? It involves the back of the head, forehead, behind the eye, along with neck pain. There's a clear connection between the neck issues and the headache, but they don't need to necessarily happen at the same time. Usually headache will trigger neck pain or neck pain will trigger headache in these situations. And sometimes only one happens at any given time. But generally speaking, there is a connection. Excuse me. And based on the anatomy I talked about a few minutes ago, usually the area of the neck that hurts the most is the upper neck, the upper cervical spine, the C1, 2, 3, 4 area. We're not talking about the shoulder blade. We're not talking about the area between the shoulder blade. We're not talking about the base of the neck. We're talking about base of the skull, really high up. Usually once it happens, then the pain is going to be there continuously. But sometimes in some people, it can come and go throughout the day. But generally, a lot of the people that I've met, they said, I wake up, I'm fine. And then around 10 a.m., 11 a.m., my neck starts hurting as I start to become active. And then that's when the headache starts kicking in. That's the most common story I'm told. Usually people with cervicogenic headache has issues with the joints of the upper cervical spine. Joints are the structures of the spine that allows you to move. Usually there's a lot of inflammation. I'm going to talk about this again in a few slides, but because there is ongoing inflammation or arthritis, as it's called, in the joints that allow the upper spine to move, often people with cervicogenic headache has limited range of motion in the neck. People come in and say, like I feel like my neck gets stuck if I try to move or turn or rotate my neck to the side where it hurts a lot. That's usually a giveaway that cervicogenic headache is likely the diagnosis. Most people that I meet say they only have symptoms on one side of the head and or one side of the neck. But I have met people who are affected by pain in both sides of the neck. Pain is usually described as steady once it comes on, and then it's achy, sharp. But it does not generally feel like an electrical sciatic pain. This is a dull, achy, throbbing, sharp kind of pain. And because this is generally due to, again, ongoing arthritis in the upper neck, it is worse with movement because usually these joints that are meant to move and glide and give you motion that's inflamed, movement makes it worse. And coughing, sneezing, sudden turn of the neck or head can sometimes trigger the neck pain, which then develops into a headache. Cough and sneeze and sudden jolt can also trigger it too. And you can see the diagram here. These are all the areas that people have reported to me in the past, that they told me comes on along with their neck pain. So as I told you, culprit number one of cervicogenic headache is arthritis. People say, well, arthritis is only in my wrist, my fingers, my knee, my hip. Well, all the joints in the body are made around the same time with same material. And so if you think of a human body as, say, a car, for instance, then you know that once one tire blows out, the second tire is coming. They're all kind of made up of the same stuff around the same time. And so when you start having arthritis in one part of the body, you betcha you're having arthritis in other parts of the body, especially the joints that give you a lot of mobility throughout your life. Your neck is highly mobile structure, your cervical spine, your lumbar spine, your knee, your elbows, your fingers are highly mobile. They're constantly moving throughout your life. And so as we get older, you wear out the meniscus or this fine structures that allow your joint to glide smoothly. They wear out, you become bone on bone, and then you start grinding the bone against each other, causing significant inflammation. So if you look at this graphic here on up top, where my arrow is, this is what a joint should look like. This is where one spine comes into contact with another spine, and there's a nice little meniscus in the middle that allows your joint to glide with every movement. But look at what happens when you lose that. And look at all this redness, and then guess what? These yellow lines that are traversing, right around these red inflamed joints are nerves. Nerves pick up this signal, this ongoing inflammation, and either they send it into the trigeminal nerve, giving you a headache, or they send it right into those nerves that are going into the back of your head. And that's how cervicogenic headache usually comes about. Culprit number two, muscles. So if you look at this figure here, we're looking at this person's back of the head, and we're looking at the junction between the skull and the cervical spine. So this is, again, the upper cervical spine. The bone is covered. We're looking at this person from the back, and you can see all these muscles, and they are in very, very, very intricately structured and layered. And there's a lot of muscles there, but you can imagine as these nerves are weaving around these muscles to get to your skin and to get into your muscles and your joints, you can see that as muscles get tight or weak and they stretch and they start, you can imagine them start pinching on these nerves and really cutting into them sometimes, because these muscles will become really hard over time, and they can start triggering nerves to generate pain signal. Muscles are very dynamic, and so depending on what posture you take, they assume different configuration, and then they can sometimes cause more irritation to the nerves that uh, and generate more pain. And so if you look at the graphic in the left, all the way to the left, of course, these muscles are not normally in this color, but for demonstration purposes, they're in different colors. But you can see that these muscles that are directly attached to the joints of the upper cervical spine create this triangular shape. And then you can imagine as the head starts tilting forward, and one starts having this forward-leaning posture, which a lot of people have as they get older, you can imagine the triangle that muscles create can narrow. Instead of having a nice triangle, it can turn into almost like an arrow-shaped opening through which all the nerves have to come. So it essentially, the muscles become tight. It starts scissoring the nerves, causing pain to come about because there's a lot of nerves that are weaving through these muscles. And you can see that the effect of that can be much greater depending on what posture you assume. So if you protract your neck, so that's the middle figure. If you start sticking out your neck like this, then you can see that the upper cervical spine changes its shape. The space in the back becomes narrower. The muscles will start collapsing. The spaces around the muscles become smaller, and then they start pinching on the nerves that are coming out. Another culprit that's really a major cause of cervicogenic headache actually is are medical conditions that we all heard of. Rheumatoid arthritis, gout, sometimes different types of osteoarthritis can all affect other joints in our body. And again, the joints that make up our upper cervical spine, they're no different. And so if you have arthritis in other parts of the body and you're getting medication for that, or you're undergoing treatment for that, and you have neck pain that goes into the head, then it's very, very possible that you have same thing going on in the upper spine, and you have to seek treatment for that as well. If you, for instance, have rheumatoid arthritis and you're getting treatment for that, or you're looking into getting treated for that, and you have ongoing cervicogenic headache, it's a really good idea to talk to your internist or rheumatologist to say, hey, you know what? I have this problem as well. It could be related. Can you look into it, please? I'll stop right there before I go into occipital neuralgia. Does anyone have any questions? Okay, so I'll move on to occipital neuralgia. So occipital neuralgia sounds like a very different condition, but you'll see in a minute, it's essentially the same thing going on and the same nerves, just slightly different. So occipital neuralgia, well, how is it different from cervicogenic headache from a person who's experiencing it? So occipital neuralgia is a neuropathic pain. So this is kind of like a sciatica pain. I told you cervicogenic headache is more like a dull, achy, throbbing, like joint pain that's worsened with movement. Occipital neuralgia is like a sciatic pain. It almost feels like there's a hit to the nerve. So it's shooting, shocking, throbbing, burning, and it can be achy, just like sciatic pain. It feels like nerve. It starts at the base of the head. Again, it doesn't generally start in the neck. It starts at the very bottom of the skull and sometimes in the middle of the skull and the back of the head, and then it shoots up to the top of the head. Again, I told you the trigeminal nerve is responsible for the face. That's the nerve that I talked about in the very beginning that comes from the brain, and it gives you sensation to the face and to the covering of the brain. So occipital neuralgia stops just short of that, and it goes into the top of the head. But it's been shown to go to the temples, and also it can shoot down into the back of the neck as well. It can, again, be on one side or both sides of the head. And there's in most people, but not always, there's a hot spot in the back of the head. And everyone knows who has this condition, they say, don't touch there. Because that person knows that if you were to touch it, well, let's say somebody kind of touches your head or tries to comb the head or cut the hair, and you touch that spot, that person who experiences occipital neuralgia knows that that will likely trigger the pain. But from anatomy standpoint, occipital neuralgia involves the same nerves as the nerves that are involved in cervicogenic headaches. And so if you look at this figure here, and you just have to look at these nerves that are highlighted in red, they come from the upper cervical spine. These are the nerves that we're talking about with cervicogenic headache. These are sitting right on the bone. They're coming through the muscles. They're weaving in and out, and they're trying to get to the back of the head. So the cervicogenic headache happens when there's issue with the bone or the joints, and then there's irritation nerves as they come off the spinal cord at the very takeoff. This is a very upstream problem, but they basically weave through the muscles, and then they eventually get to the skin. They land in the skull, and then they become occipital nerves. So they take on a different name when they become more downstream. But essentially, they are the same nerves. But once they leave the spine and then they get down to as they get closer to their final destination, which is the back of the head, they basically take on more characteristics of peripheral nerve. So that's why they feel like sciatic pain and not like joint pain. But as you can see, because they're the same nerves and the problems are kind of the similar, you can see why some people can have occipital neuralgia-like features as well as cervicogenic headache-like features. And that's why it's really hard to tease them apart. And so what I generally tell people when I meet them in clinic is that it's a spectrum. It can be more like occipital neuralgia, but it can also be more like cervicogenic headache. One person necessarily doesn't have to fit into one classic basket of diagnosis. Well, so what is a culprit for occipital neuralgia? So as you can see, it's a little different. These nerves are very far down. They're away from the spine. So usually the injuries to the nerves happen where they pierce the muscles. They're finally through. They weave through all the muscles. They finally made it. And now they're piercing through the muscles to get to the skin. And that's where the injury happens. These muscles in the back that attach to the back of your skull are extremely powerful muscles. They are the muscles that are responsible for allowing you to pull your head up. And your head is a 35-pound mass. And so in order to bring that up against gravity takes a lot of force. And these muscles are constantly working the moment you wake up until you go to bed. And so these muscles are very, very, they're very, very strong. In order to keep these muscles contained, the covering of the muscles has to be also very tough too. And so that covering of the muscles called the fascia, and these nerves have to get through the fascia to get to their final destination. So as these nerves pierce the fascia to get through, which is right here in the figure where my arrow is circling, you can imagine how the nerve can get pinched. Remember, these muscles are dynamic. They're constantly moving up and down and moving side to side to give you motion. But you can imagine that the nerve can be very vulnerable as it pierces through the fascia because the nerves are fixed in position and muscles are moving and they're constantly tugging on the nerve right where it's coming through the fascia. And so that's where the irritation can happen. And also because this is in the back of the head, and sometimes people fall in the back of the head, they can sometimes be in an accident, and they can crush the nerve as it comes through the fascia, and it can cause a nerve injury there. Once the nerve is injured, sometimes they can generate pain all by itself without a pain signal, and that can lead to a chronic occipital neuralgia situation. In very rare situation, someone can have a nerve tumor that involves the occipital nerve right in this location. And as a tumor grows, it can irritate the nerve and cause similar symptoms. Just to point out, unlike cervicogenic headache, the culprit is an injury to the nerve causing neuropathic pain. And the location where it happens is at the level of the skull, unlike the cervicogenic headache, where the issue is generally the upper cervical spine. All right, so let's talk about treatment options. So based on all this anatomy, what are we going to do about all this? Well, before we get into the treatments, I just want you to understand these key concepts. Why do we have headaches? Why do we have neck pain? Why do we have cervicogenic headaches? Why do we have occipital neuralgia? Why did God give us all these different issues that we have to deal with throughout our life? Well, the main culprit beyond all of these problems, as well as the other conditions that we have to deal with as we age, is related to age-related degeneration of joints and muscles, which means once it starts happening, that's an indication that our body has gone to a point where it's breaking down faster than rebuilding. There's a lot of degeneration happening, and that's essentially what's causing the pain to come about. And it has to do with degeneration of the joints and the bone, also degeneration and weakening and deconditioning of the muscles that allow the joints to move. And so, generally speaking, like all other conditions that we deal with, the best thing to do is to treat the underlying cause of the problem, if it can be done without significant risk. And so I just told you, generally the main culprit is degeneration, wear and tear of our body parts. So then it's very intuitive that the main treatment for the pain is to slow down the degeneration. And so there are different strategies that we can employ to slow down the degeneration, but that is the main goal. But we can never reverse or prevent wear and tear. Where continuous wear and tear is unfortunately a fact of life, but there's a lot of things we can do to slow it down or manage it. So the whole goal is to not get rid of pain. Unfortunately, no treatment out there, no matter what people promise, what people tell you, cannot completely 100% get rid of pain. But the goal is to make pain manageable so that we can all go back to our lives and enjoy all the things that we want to do without thinking about pain all the time. But I just want to give you this a good news, which is that almost everybody can achieve this goal, the manageable pain without surgery or a high risk procedure. So largely, this is how I think about it. Management for spine issues, brain issues, and neck and headache issues fall into three categories: non-surgical, procedure, and surgery. And I, as neurosurgeon, is in charge of surgical treatments, but I partner with other types of therapists and doctors who specialize in non-surgical and procedural treatments to allow people to achieve their goal of manageable pain. And that's where I put all of my emphasis. Very few people need surgery. Most people will benefit from no surgery. In fact, staying away from surgery is also a form of treatment in my mind. And we have to fully utilize all the non-surgical and procedural treatments before we even talk about surgery. So we'll go one at a time. So what does non-surgical treatment mean, specifically in regards to cervicogenic headache and occipital neuralgia? First line treatment is, in my mind, really healthy diet. And they're like, okay, well, that's kind of weird. Well, if you think about it, I told you that the biggest problem that is leading to degeneration and then the consequence, which is inflammation, is really the body's reaction to the ongoing degeneration. Inflammation is just the body's reaction to degeneration. Again, inflammation is a direct result, a direct response that the body takes to the degenerating body. So if you're able to somehow control the amount of inflammation that the body produces, then you can significantly reduce your amount of pain. And so I really think that high quality food, especially food that can combat inflammation, is probably the best medicine that you can take. That will trump any medicine you put in front of me, because this is where the game is played. This is the most important thing. You got to bring your inflammation down. And that starts with healthy diet, plenty of hydration, good nutrition. But also, believe it or not, healthy sleeping habits is incredibly important to treat pain. If you're able to maintain good sleep hygiene and get quality of sleep on a consistent basis, that's been shown to significantly decrease the amount of inflammation in the body. Also, stress management, and meditation, and mental health management, all those things actually have shown to decrease stress response and inflammation in your body, which will reduce your pain without medicines. So again, healthy sleeping habits and healthy diet, think of them as medications, and they're the most important things you can do, and not and even better than the best surgery out there. So if inflammation is too much, or a significant dietary or sleeping habit change is difficult, they are difficult, right? Then that's when we talk about anti-inflammatory medications, right? Again, this basically supports our understanding that degeneration causes inflammation. Inflammation inflames the nerves. Inflamed nerves cause pain. And that's why non-steroidal anti-inflammatory medication, acetaminophen or Tylenol, can really help. Gabapentin is a nerve-specific medication. It was initially created for epilepsy, and then people found out that how gabapentin works, and you might have heard about this medication. It's also called Neurontin, is that it increases threshold of nerve response. What does that mean? In order for a pain nerve to fire and shoot signal to your brain, there has to be a certain number of stimulation, and then the nerve will take note, do an accounting, and there's enough stimulation in a certain amount of time, it will send a signal, your brain will pick it up, and it say, okay, there's pain coming from here. But if you're able to increase that threshold, then it will take a lot more stimulation signals before the pain signal gets sent to the brain, and that's how gabapentin works. But again, I'm a strong believer, if you can avoid medications and rely on healthy diet and sleeping habits, that's the most important thing. And that's where really you're going to see huge health benefits and pain control. And just remember that good medications such as Tylenol and ibuprofen all have side effects. But other non-surgical treatments are also very important too. And they have to be done in combination with the things that I just talked about. And so this involves daily stretching, daily exercise, physical therapy, physical training becoming incredibly important as we get older. It's exercise and moving your body and your neck and your head in a healthy way, in a biomechanically sound way, is incredibly important to maintain your spine health. And the way I think about it, right? Stretching, exercise, strengthening, physical training, physical therapy, doing that routinely, doing it daily if you can, is equivalent to brushing your teeth every day to maintain dental hygiene. If you brush your teeth once a month, you don't expect to have perfect teeth. You're going to have some issues, and so the way I think about spine health, especially as we get older, is that these daily things that you do to maintain spine health becomes incredibly more important as time goes on. But some of the exercises that I recommend for people with cervicogenic headache and occipital neuralgia are the ones that are on the slide. I'll later give you my webpage address. I have all these exercises in my webpage that you can check out for free. And then if you choose to, you can do it at home, and doesn't need any special equipments. But these simple exercises using just your body weight, just the weight of the head, the strength of your arms, can really do wonders if you do it every day. Again, it's just like flossing and brushing your teeth every day. So neck retraction, I'll talk more about this shortly. Tucking your chin back, neck retraction can open up the space between the muscles and the spine and the back of your head, and it can relieve pain, especially when you're having a flare-up. A head drop is basically extending your neck like this. And why is that important? Uh, Even without knowing, as we get older, we tend to actually fall forward. The muscles starting from the neck all the way down to your toes and the front side of your body becomes stiff and tight. A lot of people can't do this. You'll be surprised. They can't do that because your strap muscles become very tight as you get older. And if you start balling up like that, then um, it actually puts your body in a very mechanically unsound way, and it can actually accelerate the degeneration of your spine. Also, what's going on is as your front side gets tight, people don't work out the back of their body. So it's called a posterior chain. The muscles that connect the back of your head all the way down to your glutes, down to your thighs, all those muscles are connected. And if you don't strengthen them and you don't stretch the front, if you don't strengthen the back, you're going to continue to fall forward, start pinching nerves in the back of your head, and you're going to be in chronic pain. And that goes actually for the rest of the spine. So movement is medicine. So cherish them, move every day, and the more you move, the less stiff you're going to get, and the happier you're going to be the long run. These two exercises are critical if you have cervicogenic headache. This basically emphasizes the point that I just made. If you have, let's see, this goes back to here. So if you assume this posture, the protraction posture, you're going to, again, start scissoring the nerves. You're going to start cramming the nerves together. You're going to narrow the space between this cervical spine and this cervical spine, and everything gets really crowded. By doing a chin tuck, you'll allow the spaces to open up. You see how much space there is now, and all the muscles are going to open up. That allows the nerves to breathe, and then it will definitely help your neck and your headache feel better. And so by doing that exercise, you're actually strengthening the muscles that allow you to do that. The more you can correct your posture, the better it is going to be for you in the long run. But this also works when you have an acute flare-up as well. And then a lot of times the reason why people have this protraction posture is because the front side of the neck, the strap muscle, is very tight. It brings the head forward, and then it prevents the neck from going back. And so there's an imbalance in the muscles. Again, a lot of us, the front side of the spine is very tight and the back of the spine is loose. And so scaling stretch, putting your hands in the chest and allowing your neck to kind of do, it's almost like a head drop, and feeling that stretch really allow your neck to become more loose, and then will allow you to do the chin tuck more effectively. And you got to do these every day. Another recommendation I have is traction therapy. It's really hard to correct your posture. I get it. And it becomes very difficult because we kind of fall into our natural posture. That's what feels comfortable. And assuming that biomechanically sound posture can be very uncomfortable and can be a lot of work. And so one thing that allows your spine to gradually open up and allow it to have the nice curvature of the neck and have a nice relationship between the skull and the neck bone is traction therapy. Traction therapy essentially pulls the spine into a more or less a normal alignment, the alignment of the spine and the relationship between the skull and the cervical spine you had when you're first born. You'll never get to that, unfortunately, but traction therapy allows you to get like closer to that than not. And there's a lot of traction devices. I recommend, if you're not familiar with it, definitely plug yourself into a physical therapy program, learn the proper way. But the one that I use is the one you can get for 20 bucks on Amazon. It's just not as sturdy as a professional one, so you probably have to buy another one within a few months instead of like a year later. But it definitely gives you an option to non-surgically allow your neck to start fixing over time. And then there are different types of therapies that are non-surgical that you can use to essentially feel better. So a lot of people ask me, well, I heard that certain therapy is not good for my neck, some therapy is harmful, some therapy I should do. Well, basically the way I look at it, whatever makes you feel better and allows you to function better throughout your day, allows you to enjoy the things that you enjoy in life, you should continue to do those things. So some people love massage, acupuncture, chiropractic manipulation. Some people wear a soft cervical collar, especially when they're traveling for a while, like in a plane, because it gives them that extra support. Because if your neck's kind of protracted, it allows you to kind of have your neck falling back into place. So all those things, either as a single therapy or as a combination of therapy with other things, can have a tremendous impact on cervicogenic headache and occipital neuralgia.
Doctor,
Yes.
what was TENS? TENS. I didn't get that.
Oh yeah. Thanks for asking that. I should have clarified. So TENS is basically a electrical stimulation device, and it comes in different shapes and sizes and forms. And you basically put it on your skin, you turn it on, it gives you that electrical sensation, which some people find it very therapeutic. Especially for occipital neuralgia, some people put it right where they have that hot spot, and then it tends to numb the area. So yeah, they're called TENS. Does that answer your question?
Thank you.
Okay. Okay. You're welcome. So, okay. So you've done your homework, you're eating healthy, you're exercising every day, and you still got pain. That's possible. That's when we start talking about the next echelon of care. And this again is done in combination with all the things that I've just talked about. So usually procedure is done by a pain specialist, a pain management doctor. And these are the same people who treat the lower spine. You've probably heard of epidural, steroid injection, nerve blocks. So, it's essentially the same concept. So for occipital neuralgia, I told you that the nerves are usually irritated where they exit the muscles that attach to the back of your skull, where the tough fascia is. And so usually the pain management specialist will inject a numbing medication or a steroid directly into the area where the nerves generally reside. And then that tends to make the pain significantly better for a long time. When that doesn't work or stops working, another option that the same doctor will prescribe or will try is a nerve ablation. And the difference between a nerve block and a nerve ablation is nerve ablation is a destructive process. Nerve block, if it is, it is using medications to stun the nerve and prevent it from working for a while, then the nerve ablation is going in with a probe, the same nerve, and then you basically burn the nerve. You essentially physically damage the nerve and hope that it won't come back. So the same thing is done for cervicogenic headache. I told you earlier that the cervicogenic headache comes from the upper cervical spine, the inflamed joints. So you can see in this figure, pain management doctor will do the same thing. They'll go in with the needle and you'll keep you comfortable. They'll put it right where they think the pain is coming from in the joints, as I mentioned earlier, usually due to arthritis and inflammation. And they'll do a facet block. What is a facet? Facet is a fancy name for the joints, that connects one cervical spine to the next. It's just a joint, but it's called a facet in the neck, because we like to have fancy names for medical, parts, body parts. But basically, facet block is when they go in and they put either a numbing medication or steroid to decrease the inflammation. So essentially, if you think about it, the medications that we take, such as NSAIDs, ibuprofen, Tylenol, that affects the entire body. It has a sort of a widespread effect in the body. But this is kind of like delivering a large payload to the exact location where the problem is coming from. And then the facet ablation is the same concept as the nerve ablation. So a doctor will go in under X-ray guidance, put a probe right to the joint, will burn the nerve where the nerves are coming out of. Now, the pain management side of things is phenomenal. When there's a runaway nerve and it doesn't respond to the healthy diet, sleeping habits, and the exercises, that usually means that there's been a runaway irritated nerve that's out of control. A lot of times these nerves will get better over 4 to 6 weeks on their own. All nerves will generally recover on their own, but during that time, you're going to be miserable. So the main job of these pain management doctors is to allow you to get a breather, get some life while the nerve is recovering. So it's buying you time, but nothing will really address the original problem, which is the inflamed joint from degeneration. But you're allowing your body to heal, and you're kind of masking the pain by hitting the nerves with different types of treatments. Well, one downside of injections, blocks, ablations is that unfortunately fortunately, our body has an amazing regenerative healing capabilities. But in this situation, it doesn't serve us well because it will regenerate nerves. And what happens, and the reason why when we get epidural for the second time, third time, fourth time, or nerve block for the fifth time, it doesn't work, it's not because the doctor sucks. That's usually not the case. What happens is when we do these injections, when pain specialists do these injections, they're going by very clear landmarks that they can see on X-ray, but you can't see nerves on X-ray. In fact, you can't see these nerves on MRI. We just kind of assume that they're there based on these anatomical studies, but everyone's nerves wire differently. And once you burn them or once you inject medication, they die and then they sprout in different pattern. So if you're going by the same landmark, but the nerves are now somewhere else, or they look different than before, and you go back to the same spot based on the same landmark, you're not going to hit the regenerated nerves as well. And how the regenerative nerves sprout and where they are and how they generate pain is completely different from the how they were before treatment. And so increasingly, the pain becomes difficult for the pain management specialist to treat. But that's very, very, few situations. Like I said in the very beginning of this lecture, most people do very, very well with non-surgical and procedure-based treatments. And that's where the story ends for a lot of people. And we're almost done with the lecture. But, I want to talk about surgery. So again, surgery, I hope I'll never have to talk to you about surgery, but surgery in general, not just in the headache and neck pain world, but in general, is only when everything else fails and pain or the problem is absolutely unbearable. If you wake up and say, gosh, because of this pain, I feel like my life is not worth living, or I can't do any of the things I like to do, that's when you have to talk to a surgeon about treatment options. Sometimes there unfortunately nothing a surgeon can do, but a lot of times there are some things we can do, but it's always at a cost. So let's talk about generally what surgeons do in the world of cervicogenic headache and occipital neuralgia. So just going back to the concept, if there's a culprit and there's an issue, surgery usually works best if you target the treatment at the problem, not at the side effects of or the consequence of the problem, but the problem itself. So I told you, cervicogenic headache and occipital neuralgia generally are due to degeneration. Well, I didn't really talk about it. So why does degeneration happen? That's because over time, our joints, our ligaments, our tendons, our muscles get weak. But those are the structures that support our spine. Our spine usually is a very, very it's an engineered marvel. But as all the supporting structures degenerate with wear and tear, the spine basically becomes very loose. When it becomes loose over time, it becomes unstable. Instability causes friction, bone on bone. The bone on bone causes inflammation. Inflammation causes pain. And this is why our body, not surgeons, our body basically develops these bony spurs all around the spine to fuse, because body knows that movement is actually the cause of the instability, which is a cause of degeneration, which is a cause of pain. The body actually over time tries to fuse the problem levels. That's why a lot of people, as they get older, are stiffer than they used to be because they've worn out all the joints, and then the spine decided to fuse to get rid of the instability. Once your spine fuses, inflammation goes away, instant. But if you allow the body to go through its natural process all the way to fusion, it takes decades during which you might suffer. That's why when it's necessary, spine surgeons like myself will fuse or offer fusion, because fusion instantly takes the body to its destination, okay, gets rid of the unstable instability, and then the body will actually get rid of all the inflammation that was going at the level, and then the pain will generally get better. So the surgeon, in case of fusion, is allowing the body to get to where it wants to go in the first place in a much faster way. So again, the next one is too much inflammation. Inflammation, again, means bone is grinding against each other. There's a lot of instability, a lot of extra motion. The body's not happy. So those people will benefit from fusion surgery. If somebody has a broken spine, and the broken spine is causing instability and spine to shift in ways that nature didn't mean it to move, then that's where, again, fusion surgery will come into play. Some people have neck pain and headache because of bone tumor. The tumor is eating up the bone, causing inflammation, causing nerves to trigger, and then that causes cervicogenic headache or occipital neuralgia. Then we usually go after the tumor. And then if there's enough destruction of the bone, then we'll have to talk about fusion surgery. As you can see, fusion surgery is a big deal. It's a lot for someone to go through. And so when you finally get to a point where you're talking to a surgeon, you better believe that you've done everything else under the sun, and now you're ready for the last resort. So surgery historically for occipital neuralgia and cervicogenic headaches been very, very gruesome and morbid. And honestly, I can't believe that, this is what we used to do just up till the 1960s and 70s. And in some places in this country, we offer this procedure as a mainstay, which is we go in, dissect all the nerves and muscles off the bone, expose the nerves, and then we cut it. And this will not only disturb all the muscles and the bone, and causing significant tissue damage, and further problems down the road. But we've learned, through experience, that when you cut the nerve, pain doesn't actually go away. It goes away for a little bit, and then it actually triggers some kind of special mechanism inside the spinal cord and the brain. When the nerve goes missing, like a phantom limb in people who have amputation, sometimes the brain will kind of turn on the switch and say, well, the nerve's missing. Well, I'm going to start doing what I want. And then we'll start generating pain within in the spinal cord and the brain, and there's no treatment for that. So neurectomy, like cutting nerves, which has been traditionally offered as a last resort surgery in these people, it can lead to some serious untreatable conditions. So this is where neuromodulation comes into play and fills the gap. So neuromodulation is kind of like the TENS unit that was asked earlier, except instead of putting it on the skin, which is really far away from the nerves, we basically bury these electrical, what we call electrode, or these wires under the skin, over the muscle, to stimulate the nerves so that the nerves come down. You basically essentially use electricity to scramble the nerves in such a way that the pain signals just can't make it into the brain. So basically, there's always going to be the degeneration and the wear and tear of the spine. I mean, that's going to progress for the rest of our lives. So understanding that, neuromodulation allows one to have not only individualized therapy, because these electrodes can go anywhere in the body, anywhere in the spine, and everyone's problem area is different, but because now we can change the program on the phone. Nowadays, now you can have an app on your phone or your device, and you can kind of treat your own pain with the program. It's durable because as your condition progresses throughout the rest of your life, you can change the program to match your needs. And because now we have the Bluetooth technology, just like you go to an app store and update your app, a lot of these device companies will provide free software upgrades, which allows you to engage in more treatment programs to find out what works best for you. And unlike neurectomy or spinal fusion surgery, neuromodulation therapies can be very minimally invasive. And if you don't like it, we just take it out. So generally, just like spinal cord stimulation, maybe some of you guys have heard about spinal cord stimulation. The electrodes go in, but a lot of times there is a trial period. And so the person who decides to go with this procedure can just try it out. So only the wires go under the skin. You try out for a week or two, and then try different programs and see if you like it. If you don't like it, then we pull the wires out in the office, and then you're done. And then we basically go and look for other options, try to better understand the problem. But if you like it, then we can basically put the whole system inside the body, and then you'll have it for the rest of your life. If you want it out, it requires just a small procedure. So it is definitely leaps and bounds better than traditional surgical approaches. And in fact, that's the reason why the FDA is constantly interested in, it's definitely interested in these types of technologies and encouraging neurosurgeons to really invest their time into educating people about neuromodulation and pushing this next frontier instead of the high risk morbid surgeries that we've traditionally been performing. So neuromodulation has been associated with reduced medication use, especially for opioid type medication, which we know are highly addictive medications. And from a regulatory standpoint, using these types of stimulation devices for occipital neuralgia or cervicogenic headache is officially off-label, meaning when the device company took these devices to the FDA for an approval, they did not specifically list cervicogenic headache or occipital neuralgia. But that's mainly a financial decision generally. They usually go for sort of a bigger market when they list indications or reasons for surgery. But because cervicogenic headache was poorly understood and occipital neuralgia was thought to be a rare condition, which now we know it's not, they did not include those conditions in the labeling. But there is ample data to support neuromodulation in the treatment of the two conditions we've been talking about tonight. So this is the one device. I work with all different types of companies. They all got pros and cons. And so if you get to this point and this is something that you're interested in, then we can deep dive into different companies and see and different treatment options associated with each device and see which one you like the best. But again, 90 to 95% of people with occipital neuralgia or cervicogenic headache don't need surgery. We don't have to ever talk about any of this stuff, that we talked about in the last few slides. And usually the success can be achieved with the medical, the non-surgical, and procedural treatments. So again, I really believe in team approach. I lean on my physical therapist, occupational therapist, chiropractor, as well as pain management doctors and internists to achieve these things, which are durable pain control, longevity in the treatment effect, improving function so that you can actually go and do the things that you want to do, which in turn feeds into high quality of life, which ultimately feeds into happy. We all want to be happy at the end of the day. And that's really what team approach allows us to consistently deliver that. So again, these are the takeaway. Headaches and neck pain can come from the upper spine. So not all headaches are coming from the head. Not all neck pain is coming from the neck. And we talked about the referred pain. So I just want you guys to kind of remember that concept. Again, the two conditions that we talked about, but a lot of other spinal issues come from degeneration, motion, which allows us to enjoy our life and do all the things that we do. The motion, all the movement that we engage in throughout our life causes degeneration. That's the cost we pay, which causes inflammation. And then aging, unfortunately, accelerates that process. And then muscle weakness can also compound that problem, and also lifestyle and certain occupations and poor posture can make the whole problem worse. So again, the whole goal is to understand, what the problem is, and then try to do your very best to modify the things that you can modify and to manage pain for the rest of your life. And this is a lifelong commitment, just like dental hygiene, spinal health, and pain is a lifelong commitment, something you have to do very regularly. And also, again, most people don't need surgery. You don't need to see a surgeon, but I'm happy to meet with you to talk about everything, um, including non-surgical and procedural treatments, to better educate you so that you can take these pearls, apply to your life, and live a happy life essentially. The last takeaway is that all these conditions that are now understood to be way more common than we previously thought require an experienced team, not just for diagnosis, but for proper management. And so it doesn't have to be me. There's a lot of great physicians in the community that partner with Providence. So I really urge you to think about who you work with, because it's a lifelong commitment, and to make sure you plug yourself in with a team of excellence so you can get the benefits that you deserve. So I know there was a long talk. Thank you so much for your attention, and I look forward to meeting you. Here's my webpage, drbrianbhwang.com. There's, again, free resources there. There's some videos that you can check out with pretty high yield educational content, exercises, stretches, and all that you can find. So make sure you check it out. If you want to reach out to me in my office, there's a telephone number, and then there's a textable number. You would text just like you can text just like you would text anybody, like your friend. Just text my team, and you can ask any medical questions, appointment requests, medication refill, whatever you need. And it will come to me and also my team. So thank you. I'll stop there, and I'll take any questions you have.